The nurses that typically I encounter are the ones that really are really scattered with their presentation when I'm meeting them to review the patient on daily rounds. And the other nurse are the other nurse type is the one that really has a really focused presentation that is really concise and isn't too verbose and isn't too much information, but concise. But they do have a deep understanding, so that if questioned, they can actually go into a little bit more detail. They have so many different patients on their mind, so to just kind of remind them what brought the patient into the hospital and a really brief, like 2 lines of the pertinent medical history that's related to why they're in the hospital. So this is a 59-year-old male that comes in with lower GI bleed, who has a medical history of, and the medical history that you list out. It would be best to hear the things that are that could necessarily affect the hospitalization. So if it's kidney failure, heart failure, a chronic anemia. So what do you, as a nurse, think of their medical history is pertinent to their current hospitalization?
So you don't want to hear about their carpal tunnel.
Correct.
Yeah.
So that's not the most important thing.
Right. Okay.
Right. So after you give a little review of what brought them to the hospital and a little short thing on what's the most important chronic medical history, the next thing is let the doctor know what's been trending with the vitals, with the labs, with the recent tests, and with the clinical situation of the patient. That's what the doctor wants to know. What's been happening in the last 12, 24 to 36 hours. And then from there, your brief 5-minute or even 4-minute little mini presentation, then the doctor can either ask you questions and then you can give a little bit more detail.
So you can give more detail and elaborate.
But maybe they don't want more detail. In terms of recommendation, you're, as the nurse, you're at the bedside with the patients a lot more than the physician. So, I mean, being that you have a very ongoing observation period with the patient, you can really be the patient advocate in terms of expressing what their needs are, like what you see in the dynamics of the family members with the patient,
right.
Or in terms of the patient, what their eating habits are, if they're eating very little or too much while they're in the hospital, if they're not moving their bowels, or if they seem dehydrated, they're not urinating, their urine output is very low. And then you make recommendations. Oh, doc, this patient hasn't been making much urine. Do we want to take a closer look at the IV fluids? Oh, doc, this patient's been very lethargic. Do you want to maybe decrease the pain meds? Oh, doc, this patient has been complaining of pain meds nonstop. Do you want to consider changing the pain regimen? Oh, doc, this patient is really unsteady on their feet. Should we get a physical therapy evaluation? Doctors want to know this stuff because this stuff affects length of stay in the hospital. And they might not be the most top of the list things that brought the patient in the hospital, but they are affecting how quickly the patient leaves the hospital. And so anything that's going to affect how long the patient stays in the hospital, you want to bring that up to the attention of the physician. So whatever the nurse can do to help the physician control that,
right.
improve
like, hey,
that.
we don't need this fully anymore. Let's take it out because that's a problem now, right?
Yes.
Okay.
Those things.
And for some reason, the patients don't like to ask you guys questions. They just, it's the doctor. They don't want to bother you.
I'll tell you, you know why?
Why?
Here's one possibility. It's called rapport, right? Physician is only with the patient for maybe 10 minutes once a day, maybe 15 minutes, maybe. The nurse is with the patient for several hours a day.
Right.
When you're with the patient for several hours a day as a nurse, you have an increased rapport with the patient. When you have increased rapport with the patient, they're more likely the communication lines are more open. With the physician, the rapport period is so short, so brief, that that's why the patient's less likely to open up to the physician because the rapport isn't there.
I think they're intimidated and have respect for you too. But
that's part of it.
But I like your theory, and it sounds like you have respect for nurses.
Of course.
I'm so happy.
Okay, here's some little tidbits of annoyance that comes out in the doctor-nurse interaction in the hospital. Okay.
Perfect.
Doctors are being paged all day long by the nurses about many different patients throughout the hospital. And so I'm getting, I think a lot of physicians as well, about a page every 10 minutes, maybe a page every 15 minutes, all day long, right? So basically it's interrupting the workflow. of seeing patients. And there's no way for the physicians to prioritize those phone calls. Like, we get a page and we don't know if it's like an emergency, dire emergency, or if it's something that is ridiculously simple. Oh, this patient needs to renew their Tylenol order, the PR, or they need to renew their DVT prophylaxis. Versus this patient's short of breath, this person's having a bright red blood rectum, this patient's having some chest pain, this patient's having a rapid AFib. And because we can't differentiate how important your phone calls are, we tend to return all the phone calls in a decent amount of time. But what happens is it really slows down the progress of our work. And so I would say about 60% of the phone calls that we get from the nurses are not urgent. 40%, 30 to 40% are urgent. So if the majority of the phone calls are not urgent, but we're calling them all anyway and getting disturbed approximately every 10 to 15 minutes, getting pages, think about the level of frustration that builds up with the doc.
I can feel it from you right now.
So it builds up, and so
right.
and I think a lot of times with the physicians, it tends to come out when they're talking with the nurse. There's irritation there. And I think that's kind of like emotional baggage, right? So,
yeah.
And it's being directed at the nurse, because I'm getting interrupted for these incessantly non-urgent phone calls, and you're calling me about something that's totally non-urgent when I've just been interrupted, 5 to 10 other times in the last 30 minutes.
Right.
I'm going to take it out on you on the phone call. You don't know anything about this patient as I'm asking you questions,
yeah.
and then they start taking it out on you because they're incessantly getting paged and broken up in their workflow about these non-urgent things. If it's a non-urgent call, kind of like hold it off for holding it off from calling the physician. The way to coordinate it is when you have a call to make to a physician, if you're on a nursing floor, I think in some of the hospitals, what happens is the nurses let the administrative assistant, they let them know who needs to be paged. Please page Dr. So-and-so. Well, that administrative assistant can actually say, oh, okay, let's wait for about the next 30 to 40 minutes and wait for any other nurses that need to page the doctor, and then we'll all reach the doctor at the same time. Correct.
Yeah.
That would help a lot.
Or like a little code.
It'd be nice if there was a little code. Yeah.
He's not breathing.
Yeah, versus 411 information. One, first of all, make sure you're prioritizing the call. And then two, next step is when you have a problem, think about how you can possibly address it, and then make suggestions to the physician, because when you're making the suggestion of how to address a problem, you're making it in the suggestion of the context of the patient. When you're talking to the physician, you're maybe sometimes assuming that the physician has in mind all the things going on with the patient, but they're seeing, 20, maybe 30 different patients on their list for that day. So there could be a little kind of confusion of who you're talking about. So when you're making a recommendation to the physician, you're making a recommendation in the context of the patient, being fresh in your mind.
Right.
When you make a recommendation to the physician about how to address whatever problem you're bringing to their attention, it could help them focus a little bit more about who they're dealing with and remind them.
A lot of the questions that they have for you, though, probably can wait until you're doing your rounds, right?
Correct. That would be most appreciated. So just kind of differentiate what questions are life-threatening and what are not life-threatening. If it involves doing a renewal for medications, for nursing care, that could wait for nursing rounds.
Yeah, right.
I get the sense that a lot of the phone calls that are non-urgent is because the nurse, one, they just want to get it over with so they don't forget.
Oh.
Or two, because they feel that it has to be charted right away in terms of when whatever situation pops up. And so they're thinking in terms of the legal, I think, ramifications. But if it's something that's not urgent, they're kind of doing it just so they can cover their butt, but it's disrupting the workflow of everything. It's probably disrupting the nurse's workflow to talk to the doc as well, right? So,
right.
So if it's disrupting your workflow as a nurse, why not kind of cluster the phone calls? So it's a matter of the nurse getting better organized so that they don't feel a pressure to constantly make phone calls out to the docs so frequently. I have a scenario for you.
Oh, great.
One nurse pages me, tells me, hey doc, this patient wants to leave against medical advice. And of course, and I'm in the situation where I'm cross-covering. So I really don't have a good history on the patient.
Gosh, that's scary.
And so it's in the middle of the night.
Yeah.
And I'm cross-covering on 150 patients or something. What I look for is for the nurse to talk to me in context of what's going on with the patient, right? and also give me some history on the patient when they're talking to me, because I can't every phone call open up the medical record, because I'm getting so many phone calls at night. It's easier if it would help if the nurse would help me figure out what's going on. So
Right.
this one particular nurse tells me the patient wants to leave against medical advice, and I say, okay, so why is the patient here? What's going on with the patient? And he tells me the patient's oriented times 4, and he's able to walk, and his father's here to drive him home. And I said, okay. And then the nurse said something about the patient was cleared by the psych evaluation team to go home. And I was like, huh, why did the psych evaluation team need to see the patient?
I was wondering.
So he says the psych evaluation team cleared the patient, said the patient can go home if he wants to. So that kind of made me think a little bit. So I asked him. I said, well, why did the psych evaluation team need to see the patient? Oh, because he was very aggressive earlier in his hospital stay and needed some help with controlling his mood. But it seems like it's better now, and he's fully oriented right now, and he can make his own decisions. So I'm thinking, okay, so the patient's oriented, has somebody to bring him home. And on top of that, I guess the patient was cleared by the psych evaluation team. So it sounds okay, I guess. And then, so I said, I guess that, if the patient knows that he still needs to be here for the IV antibiotics or whatever treatment, but he doesn't want to be treated anymore, that sounds that's okay, let him go. And so the nurse said, yeah, okay. So the nurse is getting ready to do the paperwork. And then I decide to go and open up the chart. And I see in the chart that there's a note by the psychiatrist earlier in the day that says that the patient needs a psych hold if he decides to go home. So then, I call back to the medical floor and I ask the nurse, what about this note? And the nurse was unaware about this note. Like, this is the progress note by the psychiatrist earlier in the day, in the last 18 hours. And so, in terms of the nurse calling me for an order, so he's calling me where I don't really know the patient. I'm cross-covering. And he's almost like setting me up for failure,
Right.
basically, right?
Right.
Because if I didn't look at the chart, then I would have did something that somebody else has already made a recommendation, another physician. So the nurse who's working with the patient, I would hope was more familiar about the patient than me.
Who has
because-
4 patients and you have 150?
Yeah, so
Yeah.
I mean, but the nurse didn't know that the patient was seen by the psychiatrist, so didn't know to look at the note. And I get a lot of these cases where the nurses set me up for failure. Basically, when they ask for an order, sometimes they're asking for orders, like this patient needs more pain meds, this patient's out of control. But then when you look at the progress note, then it tells you that the patient is drug seeking and has a narcotic addiction, and they have an ongoing problem of not wanting to escalate the benzos or the narcotics. And the nurses don't tell me these things. And
Yeah. It sounds to me like they're either being lazy or they're not doing the research. They're not.
they don't know their patient. Like
They
just
don't-
just
yeah.
reading the progress notes from the last 12 to 18 hours. It all has to do with rapport with the nursing staff as well as rapport with the patients.
Right.
And when there's a little rapport, then people tend to act out of context, right? When the nurse is calling the physician, they're calling the physician out of context, meaning the physician has no context of really knowing the patient because they're cross-covering.
Right.
And so the nurse just kind of blurts out stuff without giving out context of what's going on with the patient, because maybe the nurse doesn't know. Sometimes I feel like the nurse doesn't know. And the other thing is really being able to work in a very non-emotional manner. There's a lot of negative emotions in the hospital, dealing with people who are at the worst time of their lives, right? And maybe those negative emotions kind of rub off a little bit on the staff in terms of increasing our stress levels, our cortisol levels, and that causes us to maybe act in a way that's in a little bit rushed.
Right.
So really work on really trying to be neutral to the situation, and really working on empowering your mind so that you don't get overwhelmed easily, and that will improve the communications you have with the other medical staff, with the patients, when you cannot get so pulled into the negative emotions that are constantly being thrown at you from people suffering in pain, depression, and all kinds of things. Making sure you're having adequate sleep, proper
Yes,
nutrition,
right.
proper
Be
activity
prepared.
levels, exercise, and those
Right.
things all affect how you handle stress and how you process stress and how you're able to perform effectively at work.
You know, you're really smart guy.
I appreciate that. Thank
You know,
you.
you've said a couple things to me in the past, and I'm like, oh, whatever. And now, the more I learn, I'm like, he's right. We're doing a couple little scenarios following this that he's helped me compile, and it's an example of the good nurse, or the sharp nurse, and the not so good nurse. So we have little scenarios that we're going to be doing now. So thank you so much.
Those are scenarios that play out every day in the hospital.
Every day, 150 patients.
Yeah.
Wow. So when
Cross-covering
I
at
say
night.
the guy with glasses, you don't know who I'm talking about. No. Okay, on that note, bye-bye. Thank
Okay.
you.